As we move down into the lower respiratory system, we'll begin by examining the trachea. The trachea is the windpipe. It's a rigid tube about 12 centimeters long and 2.5 centimeters in diameter. It's found anterior to the esophagus, and it's supported by 16 to 20 C-shaped rings that are composed of hyaline cartilage. These rings reinforce the trachea and keep it from collapsing when you inhale. The opening in the C-shaped ring faces posteriorly towards the esophagus, and the edges of the ring are bound to each other by the trachealis muscle. This gap in the C allows room for the esophagus to expand while we swallow food and it passes by. It can also contract or relax to adjust the airflow into the lungs. The inner lining of the trachea is composed of ciliated, pseudostratified columnar epithelium. There are mainly mucus-secreting cells, ciliated cells, and some stem cells. The way that we get crap up and out of our lungs is using the mucociliary escalator. This is where mucus that's secreted by the goblet cells traps the inhaled particles, and the cilia beat upwards, driving the mucus towards the pharynx. Once it reaches the pharynx, we swallow it, and all the trapped debris is broken down in the digestive system. The middle layer is connective tissue that's beneath the tracheal epithelium. It contains lymphatic nodules, mucus, and serous glands, as well as the tracheal cartilages. The outermost layer is the adventitia. The adventitia connects the trachea to the other organs in the mediastinum. Once we move down through the main portion of the trachea, we'll see that it splits into the right and left main bronchi. It forks right at the sternal angle. And in the very last tracheal cartilage, there's an internal medial ridge. This cartilage is called the carina, and it directs airflow into the right and left bronchi. Here you can see the C-shaped ring formation with the trachealis muscle behind. You can see the layer of the mucosal cells on the inside of the ring, as well as the hyaline cartilage ring here. This is a micrograph, scanning electron micrograph of tracheal epithelium. We can see that the majority of cells are goblet cells, and the other are ciliated cells. These clumps of cilia are the ones that beat upwards to push the mucus out of our respiratory tract. They can become damaged, clumped with tar, or burned from smoking, and they don't act to move stuff up and out of the lungs effectively. That's why people develop a smoker's cough. Simply the velocity of a cough is all they have to push mucus up and out of the lungs. Here we can see a cross-section of the thorax with the heart sitting between the two lungs. Now we'll take a look at the lungs. The lungs are conical organs with broad concave bases. They rest on the diaphragm, and they have a blunt peak called the apex that projects slightly above the clavicle. The costal surface is the surface that's pressed against the rib cage all the way around the outside, and the mediastinal surface faces medially towards the heart. The hilum is the slit in the lung through which the main bronchus, blood vessels, lymphatics, and nerves pass into the lung. These structures constitute the root of the lung. The lungs are crowded by the adjacent organs. Neither fill the entire rib cage, nor are they symmetrical. The right lung is shorter than the left because the liver rises higher up on the right side. It has 3 lobes. It has the superior, middle, and inferior lobe, and it's separated by the horizontal and oblique fissures. The left lung is taller and narrower because the heart tilts towards the left and occupies more space on that side of the mediastinum. It has an indentation or cardiac impression here. It has 2 lobes, just a superior and an inferior lobe. These are separated by a single oblique fissure. Leading to each of the lobes of the lungs, we'll find the bronchial tree. This is a branching system of air tubes within each lung. The bronchial tree splits so many times that we go from one main bronchus to 65,000 terminal bronchioles. The main, or the primary bronchi, is supported by the C-shaped hyaline cartilage rings. It splits into the right main bronchus and the left main bronchus. The right main bronchus is a 2 to 3 centimeter branch that arises from the fork of the trachea. It's slightly wider and more vertical than the one on the left-hand side. This is why aspirated or inhaled foreign objects often lodge in the right bronchus more than they do in the left. The left main bronchus is slightly longer. It's about 5 centimeters long. It's narrower and a little bit more horizontal than the right. Each of the right and left main bronchi will fork into lobar bronchi or secondary bronchi. There are 3 right lobar bronchi. There's the superior here, the middle, and the inferior. One goes into each lobe of the right lung. Thus it makes sense that the left secondary bronchi or lobar bronchi have just a superior and an inferior branch. Then we go to segmental or tertiary bronchi. They're supported also by cartilage plates. There are 10 on the right and 8 on the left. Each one ventilates a functionally independent unit of lung tissue called a bronchial pulmonary segment. At the very beginning of your chapter, you can see a picture of the bronchial pulmonary segments that are supplied by each of the tertiary bronchi. This would be a great place to stop and pull together a little diagram. Just diagram a simple stick figure of how the trachea forks into the primary, secondary, and tertiary bronchi, and how many of each are located on each side. Each of these bronchi are lined with the ciliated pseudostratified columnar epithelium. The cells grow shorter and the epithelium thinner the more distally we move. The lamina propria has an abundance of mucus glands and lymphocyte nodules. This is where we'll see some of that bronchus-associated lymphoid tissue. It's positioned there to intercept any inhaled pathogens. So you can see the lamina propria area right here. It's in that middle layer of connective tissue that we see between the epithelial layer and the cartilage rings. All divisions of the bronchial tree have a large amount of elastic connective tissue. This contributes to the recoil that expels air from the lungs. The mucosa also has a well-developed layer of smooth muscle. This is called the muscularis mucosa. It contracts or relaxes to constrict or dilate the airway, thus regulating the airflow. The pulmonary artery branches closely follow the bronchial tree in their way to the alveoli, and the bronchial artery services the bronchial tree with systemic blood. This arises directly from the aorta. The bronchioles are continuations of the airway, but they lack supportive cartilage. They're 1 millimeter or less in diameter. The portion of the lung that's ventilated by one bronchiole is called a pulmonary lobule. Bronchioles have ciliated cuboidal epithelium and a well-developed layer of smooth muscle. They divide into 50 to 80 different terminal bronchioles. Terminal bronchioles are the final branches of the conducting division. They measure half a millimeter or less in diameter. They have no mucus glands or goblet cells. However, they do have cilia that move the mucus that drains into them back to the mucociliary escalator to get it out of the lungs. Each terminal bronchiole gives off 2 or more smaller respiratory bronchioles. The respiratory bronchioles have alveoli budding from their walls. They're considered to be the beginning of the respiratory division, since the alveoli participate in actual gas exchange. The respiratory bronchiole divides into anywhere from 2 to 10 alveolar ducts. Each of these alveolar ducts ends in alveolar sacs, which are grape-like clusters of alveoli arrayed around a central space called the atrium. It's here that oxygen moves from the atrium into the capillary blood supply around the alveolar sacs. And carbon dioxide diffuses from the blood back into the alveolar sacs to be expired from the lungs. So air flows then from the nasal cavity into the pharynx, through the larynx, into the trachea. The trachea splits into the main bronchi, and then lobar bronchi, and then segmental bronchi, into bronchioles, which separate into terminal bronchioles. At that point, we're in the respiratory division, where we enter the respiratory bronchioles, the alveolar ducts, the atrium, and then through the wall of the alveolus. So let's look at the alveoli in more detail. There are about 150 million alveoli in each lung. They provide about 70 square meters of surface area for gas exchange. That's about the size of a tennis court. If you're a smoker, you could take that surface area down to the size of a ping pong table pretty easily. The walls of the alveoli are made up predominantly of squamous alveolar cells. These are thin cells that are broad and allow for rapid gas diffusion between the alveolus and the bloodstream. They cover about 95% of the alveolus surface area. We'll also see type 2 or great alveolar cells. These are rounded to cuboidal cells that cover the remaining 5% of the alveolar surface. These are involved in repair of the epithelium when the type 1 cells become damaged. They are the site where we see pulmonary surfactant secreted. Pulmonary surfactant is a mixture of phospholipids and proteins that coats the inner surface of the alveoli and prevents them from collapsing when we exhale. We'll also see alveolar macrophages, or dust cells. They're the most numerous of all cells in the lung. They wander around the lumen and the connective tissue between the alveoli and keep them free of debris by phagocytosing dust particles. 100 million dust cells perish each day as they ride up the mucociliary escalator to be swallowed and digested with their load of debris. So each alveolus is surrounded by a basket of blood capillaries that are supplied by the pulmonary artery. This creates the respiratory membrane. This is the barrier between the alveolar air and the blood, right here. The respiratory membrane consists of the squamous alveolar cells, the endothelial cells of the blood capillary, and their shared basement membrane. Now, it's very important to prevent fluid from accumulating in the alveoli, because gases diffuse too slowly through liquid to sufficiently aerate blood, so we need to keep them full of air. So except for the thin film of moisture or surfactant on the alveolar wall, the alveoli are kept dry by the absorption of excess liquid by the blood capillaries. The blood pressure in the pulmonary circuit is only about 10 millimeters of mercury, and the oncotic pressure is about 28 millimeters of mercury. So the osmotic uptake of water overrides filtration and keeps the alveoli free of fluid. This low capillary blood pressure also prevents the rupture of these very delicate respiratory membranes. The lungs also have a more extensive lymphatic drainage than any other organ in the body. So now let's move outside of the lungs. The surface of the lung is covered by a serous membrane, remember, called the visceral pleura. And the outside of the cavity in which the lungs sit is surrounded by the parietal pleura. This adheres to the mediastinum, the inner surface of the rib cage, and the superior surface of the diaphragm. Between these two membranes, there's a pleural cavity. This is a potential space. There's normally no space between the membranes, but this space is occupied by a film of slippery pleural fluid. This allows the lungs to slide across other organs in the chest without friction. So in addition to reducing friction, the pleura will create the pressure gradient that's necessary to draw air into the lungs. There's a lower pressure between the pleura than the atmospheric pressure, and this assists in the lungs' inflation. The pleurae also allow for compartmentalization, which prevents the spread of infection from one organ in the mediastinum to others. So that brings us to the end of our section on respiratory anatomy. Take a moment here to diagram a pulmonary alveoli with particular attention to the respiratory membrane and its three portions. We'll see you soon when we begin to talk about some of the physiology of pulmonary ventilation.